Of our Senate Standing Committee on Health Services. And before we get into the formal agenda, I want to recognize our new committee members. Senator Herring, who's in front of me here. Senator Mills is also new to the committee, and Senator Rawlings. Also, we have a new vice chair and new member of our caucus, Senator Craig Richardson. So appreciate them being part of our committee and helping us with this great work that we do here. Yesterday, Senator Julie Rocky Adams, in her first meeting of her L&O committee, she outlined the expectations for her committee since she was a new chair. Obviously, I'm not a new chair, but I thought with three new members, give me an opportunity to talk about what we'd expect this coming legislative session. And first, I always insist that people be on time. We start on time, we finish on time. Secondly, for this session, we're going to limit the number of bills that we hear. We hear too much legislation. My last session, the last two meetings I had to hear over 16 bills, and that's not doing the process fairly. We want to make sure everybody has adequate time to air their concerns and talk about bills that we consider. So we are going to limit the bills, and quite truthfully, I hope that we have no more than 2 each committee meeting, but I will go up to the nearest 4. Senator Adams also talked about shickelizing bills, and if you've been in the legislature any period of time, you know that's the name for a past chairman of legislation, or licensure and occupational committee, John Schickel. And Senator Schickel's position always was if he didn't hear a bill during the interim, he wouldn't hear it during session. And I think that's great because, again, we need to have time to look at these bills and consider them. I won't say that we will not make an exception to that if our committee agenda is slight, that we could hear new bills, new ideas. Certainly we will do that. But, again, I encourage everyone to reach out to us during the interim if you want to have legislation heard. And obviously bills that are heard during the interim will get priority over all other bills. And last, we will not be using the consent calendar in this committee. Again, except under extreme circumstances. I can see maybe the last couple of meetings, we may be forced to do that. But again, if a bill is important enough to become the law of this state, then it needs to be heard before our full Senate. So that's kind of our ground rules. And now that Senator Adams is here, I'll be glad to go over these rules once again. But please call the roll.
Senator Rocky Adams, Senator Berg, Senator Carroll,
Here.
Senator Douglas,
Present.
Senator Herron,
Here.
Senator Mills, Senator Nemes,
Present.
Senator Rawlings, Senator Tishner, Vice Chair Richardson, Chairman Meredith.
Present. We're going to deviate from the agenda just slightly. We're going to move to the third agenda item, which is consideration of deferred administrative regulations. These have been reviewed by our allow committee members to ask questions or about any proposed regulation. Are there any questions, concerns? If not, then they're considered approved. So moving right into the agenda, we'll hear Senate Bill 14 first, and kind of take an unprecedented position on this. Usually, when the chair has a bill, we testify from the table just like everyone else does. But I think this bill is kind of unique in that it was presented during the last legislative session, passed out of the Senate 32-5 to 1, and unanimously out of this committee. So we also heard it during the interim. So I really see no need for me to make a presentation. We'll just get right into the discussion of the bill. But for the committee members, I'll call your attention to the bill itself. You see it's a 2-page bill. But the substance of it is in lines 16, 17, and 18. And basically says a manufacturer shall not discriminate or cause others to discriminate against a 340B covered entity by refusing or withholding 340B pricing for a covered drug if the manufacturer offers the same drug at a 340B price in another state. So that's the essence of the bill. To that end, we will not have a debate on 340B today because we can't change that. It's federal law. Nothing that's said in this committee today is going to change the specifics of it. I don't think there's a person involved in healthcare that doesn't realize there needs to be some adjustments to it, changes to it, but that's not the purpose of this bill, nor is the purpose of this committee today. So with that, we'll start hearing testimony. We have several people who have signed up, and I'm trying to dedicate 30 minutes to this because we have one of the bill that we have to hear today. But with that, I would invite Nancy Galvani and her group to the table. Welcome this morning. If you folks would, please turn on your mic, make sure it's lit, and introduce yourself for the record.
Good morning, Chairman Meredith. I'm Nancy Galvani. I'm President and CEO of Kentucky Hospital Association.
Good morning. I'm Don Lloyd. I'm the CEO of UK St. Clair in Moorhead, Kentucky.
Good morning. Angela Portman, CEO of
Angela, make sure your mic is on and that it's close.
Thank you.
There you go.
I'm Angela Portman, and I'm the CEO of Breckenridge Health Incorporated.
Thank you.
Good morning, I'm Brian Springate. I'm the CEO of ARH Hazard.
Appreciate y'all being there this morning. Please proceed.
So good morning, Chairman Meredith. Again, thank you so much for having KHA here today to talk about the importance of the 340B drug discount program. This is a very critical program for our hospitals and for access to care in rural communities. As we testified during the interim session, a great deal of misinformation has been floating through these halls, and it's important for the members to understand the facts about the law creating 340B and how the program benefits our patients who are your constituents. The program allows 73 Kentucky Safety Net hospitals to purchase outpatient prescription medications at the same price the pharmaceutical manufacturers offer to their best customers, which are frequently a government purchaser. Again, the medications are not given to the hospitals, they're sold to the hospitals at a federally agreed upon price, which is determined by the pharmaceutical company from its dealings with its largest customers. No taxpayer dollars are used to fund this program beyond the cost of oversight of the program by the Federal Health Resources and Services Administration. Hospitals use savings from purchasing medications at discounted prices to provide other services for their patients. According to the Congressional Budget Office, the vast majority of the savings is used to provide oncology services, making cancer treatment more readily available to patients close to their home. One of the greatest benefits of the program is that each hospital is able to offer the savings and use the savings in a manner that's consistent with the law and best serves the needs of patients in their local community. The drug companies complain that spending on the program has risen over the years, and that's true. But what they haven't explained is that the law was changed to expand the program. This expansion was done with the agreement of the pharmaceutical industry in order to have a place at the table for the creation of Obamacare. In 2010, Congress expanded the program so that more rural hospitals could participate. Critical access hospitals, rural referral centers, and rural soul community hospitals were made eligible, and that was a great benefit to rural states like Kentucky. Since that time, there's also been a shift in the delivery of health care, where services that used to be provided only on an inpatient basis can now be safely provided in an outpatient setting. So since the 340B program only applies to outpatient medication, this shift to outpatient care logically has made more medication available for the 340B discounts. Medical advancements are also contributing to growth in the program. The majority of the savings are used to pay for cancer and immunosuppressive medications. And as you all know, Kentucky has some of the highest rates of cancer in the nation, and it's a tremendous benefit for patients to receive care locally. Advanced cancer drugs are improving patient survival rates, but they come with enormous prices. And because cancer drugs are so expensive, many hospitals would not be able to continue supporting their cancer programs were it not for their 340B savings. The 340B program was also expanded by the federal government in 2010 to specifically allow covered entities to use multiple contract pharmacies. This was done to create wider patient access in recognition that many patients face transportation barriers or other obstacles that limit their ability to fill prescriptions, and this is certainly true in rural areas. Most rural hospitals lack in-house pharmacies, and they have to contract with local pharmacies to provide medications that are covered by the 340B program. The problem we face is that the large pharmaceutical manufacturers have refused to deliver the medications that are covered by the 340B program to our contract pharmacies. And that refusal by these large, highly profitable multinational corporations to deliver the medications to our contract pharmacies creates massive losses for the critical programs that our patients need. Without the savings from the 340B program, critical health services that are being supported from those savings will become unaffordable, hospitals simply won't be able to provide them, and the patients will be the ones to lose access. So we urge the General Assembly to act as many other states are doing to ensure the delivery of the 340B medications to local hospitals and their contract pharmacies in Kentucky. Kentucky is not going to be an outlier in enacting this legislation because there's at least 19 other states that are working on similar legislation, and several states, including Arkansas, Mississippi, Louisiana, Missouri, and Maryland, have already enacted this legislation. Our patients and your constituents shouldn't be treated differently than patients in other states. So please help us to make sure that Kentucky is not discriminated against by passing Senate Bill 14. And I'm joined today by these hospital leaders that can talk about the importance of 340B in their communities and how it's helping their patients. Thank you.
All right, again, I am the CEO of Breckenridge Health Incorporated. We are an independent 25-bed critical access hospital. I've been with the hospital for about 15 years and been the CEO for 10. Each year, from 2012 to 2017, our hospital lost $1 to $1.5 million annually. We had exhausted all of our reserves trying to maintain operations. In 2017, we signed our first 340B contract with local independent pharmacies, and the 340B program undoubtedly saved our hospital. We were out of options at that point. As operational revenue stabilized with the support of the 340B savings, we were able to begin offering service lines in an effort to provide more care for patients in our community and limit their travel. Some of those programs include improvements to the general surgery program, an orthopedic surgery program, podiatry, foot and ankle surgery, pain management, and chronic care management, which is a program that helps to reduce hospitalization among chronically ill patients. There are 2 other programs that we've developed and are in the process of launching that would make a tremendous difference to the communities that we serve. One of those is a chemotherapy infusion clinic in our hospital. Currently, the patients that we serve have an option to drive an hour one way to receive their chemotherapy, often many days per week. With the expensive chemotherapeutic drugs, there's no way that we could remotely consider offering chemotherapy at our hospital without 340B. Another program that we're in very early stages of implementing is a hepatitis clinic. We have a nurse practitioner who's completed all the required training to screen, diagnose, and treat patients locally, and also help to maintain the state surveillance data. The increase in hepatitis C infections in the Commonwealth over recent years is one of the highest infection rates in the country, The current drugs available for the treatment of hepatitis C range from approximately $50,000 to upwards of $90,000 for a 12-week treatment. While treatment is expensive, it's also effective. Adequately screening, diagnosing, and treating hepatitis C at the community level is believed to be one of the best ways to impact the spread of the disease, as well as prevent future costly medical complications for those who go undiagnosed and untreated. Again, without 340B, this is a service line we could not consider for our patients. We're also planning a new family medicine clinic set to open this summer in the Irvington community in Breckinridge County. We've also been able to develop a replacement facility for our Cloverport clinic. Without 340B, none of these things would be possible. Our patients would not be able to get treatments close to home, and the hospital would be very hard-pressed to keep the lights on and the doors open. Our hospital, our patients, and our community need Senate Bill 14 to pass.
Thank you, Mr. Chairman and members of the committee. My name is Don Lloyd. I'm the CEO of UK St. Clair, based in Moorhead, Kentucky. We are a regional rural referral center and support an 11-county region of northeastern Kentucky. We serve over 200 practicing clinicians, physicians, dentists, and advanced practice professionals in some of the most remote and impoverished counties in not only the Commonwealth and of Appalachia, but in the United States. We provide over 31 medical specialties through our affiliations and our relationships, and we provide post-acute services, home health, hospice, and palliative care services to patients in 11 counties. And we're the only provider in a 60-mile radius that provides acute inpatient psychiatric and acute inpatient rehabilitation and OBGYN services in that region. The community programs that we offer as a result of the savings from the 340B federal program include a chronic care program, which I'll describe in greater detail. We also support addiction recovery initiatives to reclaim the lives and dignity of those individuals who have achieved sobriety through those programs. And we also support the 26,000 visits that we incur in our oncology and infusion services program as well. Our medication assistant program, which is established to help those individuals who have fallen in the gaps, who have no coverage for pharmacy coverage. And we create access for patients with limited care options. And that is precisely what the legislation required of this program and the goal set by Congress when this program was established 30 years ago. Specifically in the addiction recovery world, we all know the scourge and how our great Commonwealth has been ravaged by the opioid epidemic and others. We partner with local rehabilitation and recovery centers to provide a continuity of service and to guarantee a medical home for individuals who heretofore often are blocked out of receiving a medical home because of their diagnosis of addiction. After initial medical detoxification and stabilization, which we provide, we use the savings from the 340B program to help establish programs to hand those patients off to recovery professionals so that those patients can receive the treatment they need to achieve sobriety and to prepare themselves for future success. We also, in addition to guaranteeing a medical home, provide those individuals access to specialty services, as many of those patients, at least 40% on average based upon our data, are suffering from one of the three forms of hepatitis or another bloodborne disease. We also established the Second Chance Employment Program for those individuals using the cost savings program, where we've offered employment to over 70 individuals who have successfully achieved that. And in addition, working with higher education institutions in our region, have established $500,000 worth of scholarship funding for those individuals so that they can reclaim dignity and achieve economic success. In our oncology infusion services, I mentioned that we served over 26,000 encounters during the last calendar year. We are the only comprehensive cancer center within an hour and 15-minute drive for our patients. And after a round of chemotherapy, that's a 2-hour burden and trip for those patients. And the number one social determinant of health in our region is transportation for people in rural areas. And we use these cost savings to help subsidize and provide transportation services, not only to oncology patients, but other patients as well. And then we established the Medication Access Assistance Program. It is an opportunity where our medical group and providers work collaboratively with our pharmacy team. And I'd like to introduce Dr. Brittany Fields and Dr. Caitlin Guerin, who are on the front row behind me, who actually practice in these clinics and work with patients that are recipients of these savings. This chronic care program, we have provided over 4,500 prescriptions to keep patients healthier, more independent, and out of our hospitals, which is a direct savings to the Commonwealth of Kentucky. But it's not just about establishing programs, it's how do we measure the outcomes. And so our 340B Medication Assistance Program is currently serving 1,000 patients on an annualized basis who otherwise would be unable to afford their medications and subsequently maintain their health. And we do that through the savings appropriated through the 340B program. We've written almost 5,000 prescriptions in fiscal 2024 at reduced costs to our patients that allowed patients to prevent rehospitalizations and address their chronic conditions. Patients no longer ration their medication in attempts to, quote, stay well enough. And the quality of life impact is immeasurable. For a grandmother with a chronic disease such as diabetes, who is caring for her 2 grandchildren, who is impoverished on a fixed income, that we can stabilize with low-cost medications so those children don't end up in foster care and that grandmother does not end up in long-term care. These programs are real and they have profound impact on those patients.
Mr. Lloyd, I'm sorry to interrupt you, but we need to wrap this up. I've got another bill, and I want to hear the other side. So if we could
Yes, sir.
close, I'd appreciate it.
Yes, sir. So I'll close in saying this, sir. This program is not a handout. It is a real benefit to the people of this state. And whether you're in a rural area of this great state or you're in the Russell or Portland areas of Louisville, people are being impacted favorably.
I appreciate that.
Chairman, members of the committee, thank you for your opportunity to speak with you today about the critical importance of the 340B drug pricing program. It's the role in ensuring the access to health care for our communities in rural Eastern Kentucky. I'm Brian Springate. I'm the CEO of ARH Hazard Regional Medical Center and a long-time practicing critical care and emergency services nurse. Appalachian Regional Healthcare operates in some of the most medically underserved areas of our state. Our hospital and clinics provide both primary and specialized care to a population that, in many cases, do not have the economic ability to receive health care elsewhere. The savings we generate through the 340B program are not a luxury, they're a necessity. They allow us to fund essential programs, keep vital services open, and to provide life-saving medication to our most vulnerable patients. One of the most significant ways that these savings is used is to fund specialty care, such as oncology services. Cancer treatment is expensive, and without the 340B program, many of our patients simply would not have access to it. Without these savings, the availability of oncology and other critical services would be in jeopardy, forcing patients to travel long distances or worse, forego care altogether. In our region, that can be the difference between diagnosis and treatment or a devastating health outcome. Over the past several years, we've already seen the effects of pharmaceutical manufacturers changing the rules of this program. Manufacturers began restricting 340B pricing to contract pharmacies with varying inconsistent eligibility criteria. There is no standard. Each manufacturer has its own set of rules, creating an enormous administrative burden for rural health systems like ours. As a result, we've had to implement a third-party administrator just to keep up with the constant changes, which diverts valuable resources away from our patients. These changes alone have cost ARH nearly $12 million annually in lost 340B savings. That's not just a number, it represents real programs and real services and real patients who are at risk of losing essential care. Further changes to this program would be catastrophic to our health system and the people that we serve. There's often a misconception that 340B is an unregulated program. That could be not further from the truth. The audits we undergo are intense and highly detailed, scrutinizing every aspect of 340B eligibility. We must account for exact timing of medication administration, patient type, address, numerous other data points. A single audit requires hundreds of hours of preparation and data submission from our team. These safeguards ensure that the program is being used properly, and they place an already significant burden on hospitals. Adding more restrictions, more complexities, and more administrative costs will only make it harder for us to provide the communities we serve. It's important to highlight the 340B program is not funded by taxpayer dollars. It's entirely supported by pharmaceutical manufacturers who, despite providing these discounts, continue to see record-breaking profits. Year after year, the pharmaceutical industry raises drug prices at rates that outpace inflation, all while cutting back on the very discounts that allow hospitals like ours to continue to provide care. The argument that 340B is harming manufacturers is simply unfounded. Their profitability remains at an all-time high, while our ability to care for Kentuckians is at risk. And let me be clear, there is not one single pharmaceutical manufacturer in the state of Kentucky. Passing protections for 340B will not harm a single Kentuckian. However, failing to protect this program will directly impact the health care of tens of thousands of our residents. It will mean fewer specialty services, fewer access to medication, and fewer life-saving treatments for people who need them the most. The savings ARH receives from 340B program allows us to fund essential programs like oncology, cardiology, and maternal fetal medicine, ensure medication access for most vulnerable patients, many who live well below the poverty line, and invest in infrastructure to keep our hospital and clinics operational in rural areas where healthcare options are limited.
Peggy, I'm sorry to interrupt you, but we're going to have to move on to in our agenda. But
Thanks, Zach.
I certainly appreciate the message you folks have sent today and emphasizing the importance of 340B funding for healthcare in Kentucky, particularly for our rural areas. I know there's other people who've asked to testify in favor of this bill. We're limited on time. I'm going to ask those who are opposing the bill to testify, and if we have any time left, which I certainly doubt we will, we'll give you that opportunity. I'll ask committee members if we could hold questions so after the other folks have spoken. So appreciate you all being here this morning. And let's move on to, I believe the first person I have on my list is Christina Moorhead with Pharma. Please, if you would, make sure the mic is on. Should it be lit green? And then identify yourself for the record, and feel free to proceed.
Chairman Meredith and members of the committee, thank you for this opportunity to present testimony today on behalf of BIO and our state affiliate, the Kentucky Life Science
If you would,
Council.
please identify yourself for the record.
I'm going to, yes, sir. My name is Russell Polk. I am the Director of Government Affairs for the Biotech Innovation Organization, also known as BIO. Kentucky bioscience industry in Kentucky, which is now includes over 17,000 jobs in the state. BIO partners with the Kentucky Life Science to ensure biopharmaceutical sector is critical to public access and the economy as it supports the development of life-changing treatments and cures through research and development partnerships with Kentucky state universities, clinical trials for new medicines, and distribution of specialty treatments. Kentucky must remain at the forefront of the biopharmaceutical research, manufacturing, and biologics to ensure a healthy economy, workforce, and population. However, our members believe Senate Bill 14 does not protect our patient savings through this 340B legislation. It does not help patients lower their out-of-pocket costs, makes it more difficult for state, payers, and manufacturers to identify illegal duplicate discounts and diversion, which is waste in the system, and codifies contract pharmacies in statute, a part of the program that has led to inappropriate growth, which is not included in federal statute and is subject to pending litigation. Senate Bill 14 would expand federal law far beyond what Congress intended while doing nothing to benefit access to the care of Kentuckians.
I'm sorry, but I can't accept that statement. I don't believe that's true. And I'd ask you to speak to the bill as to why Kentucky should be singled out and discriminated against by withholding 340B pricing.
I'm sorry, I missed the question.
So again, we're not debating 340B today.
Okay.
I asked you to speak to the bill as to why Kentucky should be singled out and be denied 340B pricing when other states are allowed to have it.
Senator, I'm not sure that Kentucky is left out of the states. I
You
mean,
most certainly are. If we're not receiving the discounts, then we've been left out. Other states are receiving it. Kentucky's not. It's pretty straightforward.
yes, sir. For these reasons, Bio opposes Senate Bill 14, and I'll turn it over to Jenny.
Thank you, Senator Meredith. Let me get closer to the microphone
Thank you.
and the rest of the members of the committee. My name is Jenny Goins. I am the Chief of Staff for the National Alliance of Healthcare Purchaser Coalition. Some of you may remember me testifying in front of you when I was Commissioner of the Kentucky Employees Health Plan. I am here totally to talk about the impact of Senate Bill 14 on employers and their families. The whole mission of the National Alliance, and the reason that I'm here in that perspective, is that we look across the country and in states, in regions of healthcare to really bring value to employers who cover 60% of health insurance across the country. 340B is an excellent program, but it has become flawed. So we're not here to say...
Again, I hate to interrupt you. I understand the program is flawed. I think all of us understand it's flawed. What I
yes,
want
sir.
you to speak to is why Kentucky should be singled out, which this bill provides protection for 340B qualified entities in Kentucky, protects funding for Kentucky. Why should we not be allowed to have this funding when other states are?
I appreciate that thought, Senator Meredith, and the reason that we, along with the Kentucky Association of Manufacturers, oppose Senate Bill 14 is the fact that we don't understand the costs to employers. So while
We'll
this
be glad to explain that in the future. I would just ask you
Well-
to speak as to why Kentucky should be discriminated against.
I'm not saying Kentucky should be discriminated against.
And that's the essence of the bill, so what are we discussing?
So we're discussing why there's no fiscal note. We would like to see
Does it require a
transparency.
fiscal note?
No, but what we would say is this program has grown to $66.2 billion.
Not in Kentucky, it hasn't.
It has grown. Well, we don't know that for a fact, sir. So
We do
my
know
point
it's
is,
about 122 million for Kentucky, 70 million that go to rural hospitals specifically, and that represents about 0.0018% of the total funds expended for 340B.
I would ask that from a transparency perspective, and it's not Jenny Goins asking, I'm sorry, sir. It is the National Alliance and others representing employers, that we look at what and get an eye into this expensive program that does a lot of good, but what is happening is hospitals and others buy 340B drugs. Employers do not get advantage of the rebates, which is about $5 billion.
They don't get the
$5
advantage of the rebate because that's not the intent of the program. It was
No,
started in.
but what happens, sir, if I could interrupt just 1 second, is a provider who's authorized, like a hospital, to purchase drugs at a 340B rate might pay $500, but then they're charging the commercial plan, the self-insured employers, the state health plan and others, they're charging the plan the negotiated rate.
Which is the intent of the program to begin with.
So, for example, in North Carolina, by looking and using transparency and fiscal notes,
Let's
North
talk
Carolina
about Kentucky.
has.
I don't want to talk about North Carolina. Let's talk about Kentucky.
This is just
Do you know
an
of any
example.
facility, any healthcare provider in Kentucky that has abused this program?
I can't tell you that because we don't have transparency.
Then let's
sir.
move on. Anyone else?
Chairman Meredith, members of the committee, thank you for having me today to offer testimony in opposition to Senate Bill 14. My name is Christina Moorhead. I'm a Deputy Vice President of State Policy for the Pharmaceutical Research and Manufacturers of America, or PhRMA. We represent the country's leading innovative biopharmaceutical research companies who support critical scientific advancements at Kentucky's research universities. So while we oppose Senate Bill 14, I would like to note at our outset today that we and our member companies strongly support the original intent of the 340B program, which was intended to help low-income and other vulnerable patients access medications they might not otherwise be able to afford. In the interest of time, I am limiting my testimony today to address two misrepresentations of this bill. First, that Senate Bill 14 ensures that Kentucky is treated the same way as every other state regarding 340B pricing, and second, that Senate Bill 14 will increase access to prescription drugs for patients. We've also provided committee members with our full testimony in writing that goes further into the legal issues and concerns with how Senate Bill 14 would increase costs for employers, patients, and taxpayers. So proponents of Senate Bill 14 have claimed that the purpose of the bill is to ensure that Kentucky is treated the same way as every other state regarding 340B discount pricing. But in reality, Senate Bill 14 is looking to join just 8 states who have passed similar legislation requiring that drug manufacturers provide discounted 340B prescription drugs to pharmacies contracted with a 340B discounted 340B covered entity. Of note, litigation on these state laws is currently occurring in courtrooms across the United States. Like these other states, Senate Bill 14 looks to expand the 340B program, a federal drug pricing program, to mandate drug manufacturers provide 340B pricing to pharmacies by redefining the definition of 340B covered entity in state law to include pharmacies contracted with a 340B covered entity.
But this bill does not change that.
This bill does change that. Your definition
it
of
does not
340B covered entity
change
is
that.
not the definition in federal law.
We beg to disagree, but let's continue.
Okay. To understand the changes Senate Bill 14 is attempting to make to the federal 340B program, it is important to understand that the 340B covered entity definition under federal law includes a defined list of hospitals and clinics, and drug manufacturers ship 340B prescription drugs to these entities as required by federal law. However, pharmacies are not considered a 340B covered entity under federal law, and they were not contemplated by Congress when the original law was enacted in 1992, when it was amended in 2010, or since then. So by creating a new definition of 340B covered entity in state law that includes pharmacies contracted with a 340B covered entity, Senate Bill 14 expands the federal 340B program beyond what was intended by Congress. And so the claim that Senate Bill 14 merely ensures that Kentucky is treated the same way as every other state regarding the 340B discount pricing program is simply untrue. Proponents of Senate Bill 14 have also claimed that the bill will improve access to prescription drugs. However, we know from their own testimony that they do not use the discounts from the 340B program to solely lower the price of prescription drugs for patients. So patient access from an affordability perspective is not changed by Senate Bill 14. And additionally, prescriptions provided to a patient from a 340B covered entity can now and have always been able to be filled by any pharmacy. And Senate Bill 14 has no effect on the availability of a prescription drug at a hospital, a clinic, or a pharmacy. So patient access from an availability perspective is also not changed by Senate Bill 14. So for these reasons and also the reasons we've outlined in our written testimony, we respectfully ask for your no vote on Senate Bill 14, and we're all happy to answer any questions.
Thank you. Does anyone else want to speak against this bill? If not, I'd entertain questions from committee members. Senator Berg.
This is really more of a statement than a question, because I want to answer some concerns that my constituents have sent me in emails. The purpose of the 340B drug pricing program is to support healthcare facilities. It is to keep the doors open for those places that people need to be able to receive health care. It is not supposed to decrease the individual cost to an individual person. And I have constituents who are saying, wait, if we're going to give these 340B prices, we need to give them to the actual patient. What people don't understand is those actual patients will not have working healthcare facilities to be treated at without this program. So even though ideally what we would do is lower the cost of healthcare for every person, that's not what we're talking about here. What we are talking about here is a federally controlled program that we cannot actually change on the state level. We have no control to do that. But what we can do is make sure that if drug companies are giving discounts to other facilities in other states, we get those same discounts here in Kentucky. That is all this bill is doing. And I really encourage my colleagues to vote yes. For any of my constituents that still have concerns about this, call me. I would love to talk this through with you. I think it's a misunderstanding of what this program is intended to do and what the program is actually doing, which is what it was intended to do. Keep the doors open so that we can actually provide things like chemotherapy to patients in their home counties. Thank you.
Senator Douglas.
Thank you much, Mr. Chairman. I'd also like to make a comment as well before we vote.
Please.
Thank you very much. In reviewing the data regarding 340B, it allows hospitals to stretch scarce federal resources to maintain, improve, and expand to support a variety of patient services and programs to improve their offerings of health care. I'd like to piggyback on what Senator Berg has just said. I think one of the issues, and I'm kind of known for saying things that other people won't say, but I think what we're finding is we're finding an intersection between, and this is not bad, a healthcare model and a business model, folks. That's really what we're talking about here, and that's not meant to be a criticism at all. I hope this helps people understand what we have to grapple with each and every day. 340B actually does give options to the people who are administering the program at their hospitals. Sometimes those advantages are directly to the patients in terms of reduction in medications, and sometimes those benefits are indirect to the patient in terms of hospital improvements, equipment upgrade, diagnostic upgrades. We focus all the time on medications. And those of us in the healthcare space don't want our patients on medications. We want them to get well. And if we can help them get well without medications, we would love to do that. And believe it or not, our diagnostic studies and the information that we get help us determine different ways of how we can best treat our patients. You know, one of the we can talk about what some hospitals do and what other hospitals don't do, but I'm continually saying here at this desk, we can't legislate honesty as much as we'd love to. We would love to legislate honesty, but we can't. We can't. We cannot legislate goodwill. I'm continually saying 23% of the healthcare that I provided when I was providing healthcare, I did not charge patients for. Doesn't make me a good guy. It doesn't. I just understood how honored and how lucky I was to be able to practice medicine. If hospitals close, there will be no care locally. None. And you talk about inconveniencing patients. I think I just want my fellow members of the committee to consider some of these facts. I'm not telling you how to vote. I'm just wanting you to consider some of these facts as we make this decision. Thank you very much, Mr. Chair.
Final question from Senator Nemes, and before you address that, Senator Funky Fromeyer, my sincerest apologies for encroaching on your time, but we'll get to you shortly.
I'll be
hopefully.
brief then. I want to make a clarification, if I may.
Yes,
Mr.
please.
Chairman. This is a way that the feds came in and helped subsidize struggling medical facilities, and the pharmaceutical company agreed to that for whatever reason. They were squeezed. I think they're good people. Whatever, they agreed to this, and it has expanded, and they're not making as much profits. But even at a discount, they're making a profit. But I also want to make a comment on what you were saying about businesses. You have legitimate cost to Kentucky businesses, because what can happen is the patient will pay more for the drug. In lieu of that, their insurance pays for that. Their premiums may go up. So you were trying to make a legitimate argument that Kentucky is different than other states, that their premiums may be lower because they're not do not get the benefits other states do. Now, I'm going to vote for this because I think we should get the same. But I want to clarify that you were making a legitimate argument about businesses in Kentucky. Thank you.
Mr. Chairman.
Thank you. Is there a motion on the bill?
Mr. Chairman, I make a motion on the bill.
Motion, is there a second?
Second.
Second. All those in favor vote aye. All opposed vote no. Becky, please call the roll.
Senator Rocky Adams. Senator Byrd. Senator Carroll.
Aye.
Senator Douglas.
Aye.
Senator Herron.
Pass.
Senator Mills. Senator Nemes.
Aye.
Senator Rawlings.
May I make a comment?
Yes, please.
In all due respect, I've heard from dozens of my constituents who asked me to vote no, so respectfully, I'm voting no. The common theme that I heard from them is the discounted savings aren't passed through to the patient. Thank you.
Senator Richardson.
Yes.
Senator Tishner.
Can I make a comment, please?
Yes, please.
I'm going to vote yes because I said I was going to vote yes. This is a very big issue. It's one I think we really could use a lot more time on. Obviously, almost took up this entire committee. Something I would like to see from this legislation as it moves forward is possibly clarifying a way that we can have transparency of pricing and transparency of usage of that additional funds that if SB 14 moves forward, that's going down to the hospitals and the outpatient centers. How is that money being used? I love what I'm hearing from our rural communities, hospitals, and outpatient centers and how it's being used now. I would just like to have continued transparency on those additional funds. Thank you.
Chairman Meredith.
The vote is 9-1-1. The bill passed with favorable expression. Thank you for being here this morning.
Thank you for your time, sir.
Thank you. Senator Funky Fromeyer, if you'll come to the table. Again, my apologies to you. But quite candidly, this is my 9th year in the Senate, and I think we have been working on this bill at least 8 of those years. And many of the issues that I've had in the past have been resolved. So I congratulate you on your endurance, and as well as the folks that you have at the table today. A lot of the issues have been addressed. So to that end, please proceed with identifying yourself for the record and let's testify on the bill.
Absolutely. Thank you. And I'm Senator Shelley Funky Fromeyer from Senate District 24. And I do appreciate, Chairman Meredith, that you're hearing this. And out of deference to my fellow colleagues that have, I believe, 9:30 committee meetings, I would like to just give us an opportunity to address any further questions and just give a very quick summary and acknowledge that the remainder of the panel and Leader Nemes has also schickelized this, using your words, in the interim. And this is the bill that we reviewed in the interim. So many on this committee saw it then, but also to acknowledge that freestanding birthing centers lead towards that wellness that we've discussed and the importance of a place for a physiologically natural birth. And these are expected to be operated on a midwifery model with that wellness of prevention, sensitivity, safety, appropriate medical intervention, and cost effectiveness. So on that note, we can address any further questions, but we would like to give you an opportunity to wrap it up in a meaningful time.
Well, no, again, speaking on the evolution of this bill, and that's what it has been. My concerns from the beginning were the lack of professional liability insurance, the lack of transfer agreements with hospitals and ambulance services, and also the qualifications of medical director. And those have been adequately addressed for me. And I think it makes a much better bill, a much safer bill. So again, I don't know what else we need to discuss with regard to this, but the floor is open for questions. No question, I'll entertain a motion. We have a motion and a second. All those in favor vote aye. All opposed vote no. Maggie, please call the roll.
Senator Rocky Adams.
May I explain my vote, Mr. Chairman?
Yes, please.
Thank you. I'm just so excited to vote aye for this bill because so much hard work has gone into it. And so I applaud the sponsor for her tenacity. And I also applaud our House Majority Whip, Jason Nemes, for all of your work on. We talk about it ad nauseum. And I think this is a great day for options for pregnant women in the Commonwealth. And so great job.
Senator Berg.
I vote aye, and I'd like to explain my vote just a little bit.
Yes, please.
Because honestly, if you'd come to me a couple of years ago and asked me what I thought about freestanding birthing clinics, I would say no. I chose to have my children in a facility where there was an ICU attached to the building in case, God forbid, that was necessary. But the paternalism in medicine is ending. And it is a patient's right to decide where and how they want to deliver their children. So even though honestly this is a decision I would never make for myself, nor is it a decision I would ever encourage a family member to make, because I'm not scared of medicine, I'm not scared of hospitals. I think the doctors and nurses work in the best interest of patients. But for those people that are so desperately wanting an alternative, they deserve it. So thank you. I vote yes.
Senator Carroll.
Aye.
Senator Douglas.
Explain my vote.
Yes, sir.
Mr. Chairman, I think Senator Fromeyer has done a wonderful job. I'm going to pass on this vote, and I'll tell you why. In the healthcare community, I also have to interact with a number of people who are the boots on the ground, and unfortunately, a number of people who have to take care of the complications that occur as a result of some of these decisions. And I understand what Dr. Berg is saying. Oh, Senator Berg, I'm sorry.
Oh, it's okay.
Senator Berg is saying. And given that, just in good conscience, I have to pass. But I'm not here to destroy the concept nor destroy your bill. Right. I think you've done a wonderful job. Thank you, Mr. Chair.
Senator Herron.
Yes.
Senator Mills.
I vote aye.
Senator Nemes.
Aye.
Senator Rawlings.
Aye.
Senator Richardson.
Aye.
Senator Tishner.
I vote aye with 2 enthusiastic thumbs up.
Thank you.
Chairman Meredith.
Aye. The vote is 10-1. Obviously passed with favorable expression. Congratulations to you.
Thank
And
you.
I know this is the first step in this journey, but we'll make note to you that kind of unprecedented for me is that we received an email from the governor's office that they have a fiscal note on this. So I would suggest that you take a look at that as we continue down this legislative.
Senator, we will do that. I will note that I've filed this bill for 5 years in a row, and the morning that it's coming to committee, we get an email from the governor's office. I do not accept that as professional nor acceptable. We will work with them, but I call into question the good faith of that after this has been filed for 5 years and has gone through the House. Thank you.
I appreciate that. Obviously, I'm not saying that I give credibility to the fiscal note itself. Just kind of a heads up to everyone. But appreciate y'all being here this morning, and good luck going forward. Bill does pass with favorable expression. Is there any other business come before this committee? If not, entertain a motion to adjourn. Motion. All in favor, stand up. Thank you.
All right.
Yes, thank you. And I'm so sorry you didn't have an opportunity. Okay, definitely want to spot on the stage. Yeah. Okay. Yeah.